Question 1. Radiation therapy techniques. A patient with non-small cell lung cancer (SLC) has a centrally located tumor close to the mediastinum and major blood vessels. The radiation oncologist is considering stereotactic body radiation therapy (SRT) as a treatment option. However, concerns arise due to the tumor's proximity to critical structures. What would be the most appropriate course of action in this case? A. Proceed with SRT using standard hypofractionated regimen without modifications. B. Use intensity modulated radiation therapy (IMiT) instead of SRT to better spare surrounding tissues. C. Modify SRT parameters by reducing dose per fraction and incorporating advanced motion management techniques. D. Disqualify the patient from radiation therapy and refer for surgical resection instead. Answer: C. Modify SRT parameters by reducing dose per fraction and incorporating advanced motion management techniques. Explanation: Stereotactic body radiation therapy (SRT) delivers high-dose radiation in a few fractions, making it highly effective for treating lung cancer. However, for centrally located tumors near critical structures, e.g., major blood vessels, the heart bronchi, standard SRT dose fraction schedules can increase toxicity risks, such as bronchial stenosis, hemorrhage, or radiation pneumonitis. ASTRO guidelines recommend using modified SRT regimens for central lung tumors, such as lowering the dose per fraction e.g. 50 Gi in 5 fractions instead of 54 Gi in 3 fractions. Motion management techniques like respiratory gating and forward CT planning are crucial to minimize dose to surrounding normal tissues. IMiT option B may be beneficial for dose conformality but does not provide the same tumor control SRT for early-stage SCLC. Surgical resection, option D, remains an option but is not always feasible, especially for patients with medical comorbidities. Question 2. Radiation oncology safety and quality assurance. During a routine quality assurance check-on, a linear accelerator, the medical physicist identifies that the output dose deviates by 4% from the baseline measurement. According to standard radiation safety and quality assurance protocols, what is the most appropriate next step? A. Continue treatment as usual since the deviation is within an acceptable range. B. Immediately halt all patient treatments until the issue is fully investigated and resolved. C. Recalibrate the linear accelerator and perform further cut checks before resuming treatments. D. Report the deviation to regulatory authorities and conduct a root cause analysis before making any adjustments. Answer: C. Recalibrate the linear accelerator and perform further cut checks before resuming treatments. Explanation: Radiation therapy equipment must adhere to strict quality assurance and calibration standards to ensure accurate dose delivery. OPAM Task Group 142 recommends that the daily output variation for a linear accelerator should not exceed 3%, and weekly cut checks should confirm consistency. A 4% deviation exceeds tolerance limits, requiring immediate corrective action. Recalibrating the machine and conducting additional cut tests, option C, ensures that the deviation is corrected before patient treatment continues. Stopping all treatment indefinitely, option B, is unnecessary unless the deviation is significantly higher or poses an immediate risk. Reporting to regulatory authorities, option D, is usually required for deviations exceeding 5% or in cases where errors may have impacted patient safety. Question 3. Scenario-based clinical oncology and radiation oncology applications. Dr. Patel is treating a 58-year-old woman diagnosed with locally advanced cervical cancer, stage IB, with parametrial invasion. The patient has completed 5 weeks of external beam radiation therapy (EBA) to the pelvis. As part of the standard treatment protocol, the next step is to initiate brachytherapy. However, the patient is reluctant to concerns about discomfort and side effects. What should Dr. Patel do in this situation? A. Respect the patient's decision and complete treatment with an additional boost of EBA instead. B. Educate the patient on the necessity of brachytherapy and address her concerns to obtain informed consent. C. Switch to systemic chemotherapy as a substitute for brachytherapy. D. Refer the patient for palliative care, as further treatment would be ineffective without brachytherapy. Answer: B. Educate the patient on the necessity of brachytherapy and address her concerns to obtain informed consent. Explanation: For locally advanced cervical cancer, brachytherapy is an essential component of definitive radiation therapy and has been shown to improve local control and survival. The American Brachytherapy Society AMPS and NCN guidelines strongly recommend brachytherapy following pelvic EBIT. Omitting brachytherapy, option A, using an EBIT boost alone is not equivalent in efficacy and is associated with worse outcomes. Systemic chemotherapy, option C, does not replace the need for brachytherapy in this setting. Palliative care, option D, is not appropriate, as the patient still has curative treatment options available. Instead, the physician should counsel the patient on the importance of brachytherapy, provide information about pain management, and then discuss potential modifications, such as sedation or anesthesia, to improve comfort during the procedure. Question 4. Radiation physics and dosimetry. A radiation oncologist is calculating the absorbed dose for a patient undergoing external beam radiation therapy EBIT for prostate cancer. The prescribed dose is 7 to 8 GI delivered over 39 fractions. During quality assurance testing, it is discovered that the linear accelerator was under-delivering the dose by 3% per fraction due to a calibration error. What is the appropriate course of action according to radiation safety and dosimetry protocols? A. Continue the treatment as planned, since the total dose reduction is within acceptable limits. B. Adjust the remaining fractions to compensate for the missed dose while ensuring the overall treatment remains within tolerance limits. C. Restart the entire treatment plan to ensure uniformity in dose distribution. D. Report the incident to the Radiation Safety Officer, RSO, but continue treatment without modifications. Answer. B. Adjust the remaining fractions to compensate for the missed dose while ensuring the overall treatment remains within tolerance limits. Explanation. According to OPAM task group reports and ACRASTRO guidelines, dose deviations greater than 2% should be addressed in treatment planning. A cumulative 3% reduction per fraction over 39 fractions results in a significant underdose while restarting treatment. Uniformity. It unnecessarily prolongs therapy and increases toxicity risks. The best approach is to adjust the remaining fractions to compensate for the dose deviation while keeping within tolerance limits. The ELIRA as low as reasonably achievable principle also requires that such deviations be corrected efficiently to maintain therapeutic effectiveness. Question 5. Clinical oncology and radiation oncology applications. A 45-year-old woman with a history of ERCA mutation is diagnosed with locally advanced triple-negative breast cancer (TAC). She undergoes neoadjuvant chemotherapy followed by mastectomy and is now being evaluated for adjuvant radiation therapy. The radiation oncologist is considering hypofractionation. Which of the following is the most factor in determining whether hypofractionation is appropriate in this case? A. Tumor histology and molecular subtype. B. Post-mastectomy margin status and presence of nodal involvement. C. Patient's age and overall performance status. D. Prior exposure to chemotherapy regimens. Answer. B. Post-mastectomy margin status and presence of nodal involvement. Explanation. The decision to use hypofractionated radiation therapy (HRT) in breast cancer depends primarily on tumor control factors. According to ASTRO and NCEN guidelines, post-mastectomy radiation therapy (RT) is indicated for patients with positive surgical margins, extensive nodal involvement, 4 positive lymph nodes, or other high features. While tumor histology and molecular subtype (TNEC) may influence prognosis, hypofractionation decisions are based on margin status and nodal burden rather than specific tumor biology alone. Younger patients with BRCA mutations are not an absolute contraindication (TAT) if normal tissue constraints are met. Question 6. Imaging in radiation oncology. Scenario-based. Dr. Patel is planning radiation therapy for a patient with a glioblastoma multiforme (GBM). The treatment plan involves image-guided radiation therapy with a 60 GI total dose. The planning team is evaluating different imaging modalities for treatment planning and target delineation. Which imaging approach is most appropriate to ensure optimal tumor coverage while minimizing dose to surrounding critical structures? A. CETA-based planning alone, as it provides accurate electron density information for dose calculations. BMRI-based planning, including diffusion-weighted imaging, DOI, and perfusion sequences to better define tumor extent. C. PET fusion, as PET metabolic activity provides the most precise tumor boundary. D. Ultrasound-guided target localization to monitor treatment response in real time. Answer. BMRI-based planning, including diffusion-weighted imaging, DOI, and perfusion sequences to better define tumor extent. Explanation. Glioblastomas are highly infiltrative tumors, and conventional CT imaging does not adequately differentiate tumor from edema or normal brain tissue. MRI-based planning, especially with diffusion-weighted and perfusion imaging, is essential for precise tumor delineation. PET imaging can complement MRI but is not sufficient as a standalone modality due to its low spatial resolution. Ultrasound is not a standard tool for intracranial radiation therapy. ASTRO guidelines recommend MRI for radiation planning in CNS tumors to optimize target delineation. Question 7. Radiation therapy techniques. A patient with stage I non-small cell lung cancer (SLC) is being considered for stereotactic body radiation therapy (SRT). The treatment team is deciding between 5-fraction versus 3-fraction SRT while considering tumor motion due to respiration. Which of the following is the most important factor when determining the optimal fractionation scheme for this patient? A. Tumor size and proximity to central structures. B. Pulmonary function test (PFT) results and baseline lung capacity. C. Previous history of thoracic radiation therapy. D. Performance status and comorbidities. Answer A. Tumor size and proximity to central structures. Explanation: SRT is commonly used for early-stage SLC, but dose fractionation depends on tumor location and size. Larger tumors and those near central structures, e.g. bronchi, major vessels, heart, require more fractionation, e.g. 5-fraction SRT, to reduce toxicity risks. Peripheral tumors can tolerate 3-fraction SRT due to low risk. Damage to critical organs. According to ARTOGS 0813 and NRG protocols, tumors 2 cm or close to critical structures should be treated with a more fractionated approach to improve safety. Question 8. Radiobiology. Radiation-induced DNA damage occurs through several mechanisms, and different cell types have varying repair capabilities. Which of the following cell types is most resistant to radiation-induced apoptosis? A. Hematopoietic stem cells. B. Neurons. C. Gastrointestinal epithelial cells. D. Squamous epithelial cells. Answer B. Neurons. Explanation: neurons are highly differentiated and postmitotic, meaning they are highly resistant to radiation-induced apoptosis. In contrast, the hematopoietic and gastrointestinal epithelial cells are highly radiosensitive due to their high turnover rates. Squamous epithelial cells are moderately radiosensitive but still more prone to radiation-induced damage than neurons. Radiation resistance in neurons is attributed the low proliferative rate and reliance on non-apoptotic DNA repair pathways, e.g. non-homologous end joining. Question 9. Radiation oncology safety and quality assurance. A radiation oncology department is implementing new automated treatment planning software using artificial intelligence (AI) for dose optimization. What is the most critical safety measure to ensure quality and compliance with regulatory standards? A. Conduct retrospective plan evaluations comparing AI-generated and human-created plans. B. Implement a full department transitioned AI-based planning to reduce variability. C. Rely solely on AI-generated plans to improve efficiency and reduce workload. D. Allow AI-generated plans only for palliative cases with lower dosimetric complexity. Answer A. Conduct retrospective plan evaluations comparing AI-generated and human-created plans. Explanation: AI-based treatment planning has the potential to improve efficiency, but quality assurance must be maintained. Retrospective evaluation comparing AI-generated plans with human-created plans ensures safety and regulatory compliance. Full department transitions without validation. Option B. Post-signal risk. AI should be a tool to assist, not replace, human oversight. According to ASTRO and OPAM guidelines, all AI-integrated systems must undergo rigorous testing, independent verification, and clinical validation before widespread implementation. Question 10. Radiation therapy planning. Head and neck cancer. A 55-year-old male with TTM oropharyngeal squamous cell carcinoma (OPSC) is undergoing definitive chemoradiotherapy with intensity-modulated radiation therapy. The prescribed dose is 70 Gy to the primary tumor and involved nodes, 59.4 Gy to high-risk subclinical disease, and 54 Gy to elective nodal regions. Which following is the most critical constraint in planning the IMiT dose distribution? A. Mean dose to the contralateral parotid gland. B. Maximum dose to the brainstem. C. Dose homogeneity within the planning target volume (PTV). D. Spinal cord dose exceeding 50 Gy. Answer B. Maximum dose to the brainstem. Explanation. While all constraints are important, the maximum dose to the brainstem is the most critical. Doses exceeding 54 Gi to the brainstem can cause severe neurotoxicity, including necrosis or brainstem dysfunction. The spinal cord is another key structure, but the standard constraint is 45 Gi, meaning 50 Gi threshold should have been accounted for in initial planning. Parotid sparing mean dose 25 Gi is important for reducing xerostomia, but it is not life-threatening. IMIT's primary role in head and neck cancer is balancing tumor coverage with critical organ sparing. Question 11 SRT versus conventional radiation for lung cancer. A 72-year-old patient with stage IA cell AM has poor pulmonary function, equals 40% predicted, and is deemed inoperable. The radiation oncology team is considering stereotactic body radiation therapy SRT versus conventional fractionation. What is the primary advantage of SRT over conventional radiation therapy for this patient? A. Low risk of local recurrence. B. Reduced radiation pneumonitis risk. C. Fewer treatment-related cardiac toxicities. D. Improved long-term survival. Answer A. Low risk of local recurrence. Explanation. SRT delivers highly conformal ablative doses, resulting in superior local control compared to conventional RT. Studies RTOC 236 demonstrate SRT achieves local control rates 90% for early-stage SLCO, whereas conventional fractionation 6066 Gi in 3033 fractions has high recurrence rates. With SRT may reduce some toxicities, radiation pneumonitis remains a concern, especially for central tumors. Survival benefits are largely equivalent between SRT and conven RT in medically inoperable patients. Question 12. Reirradiation considerations in radiation oncology. A 60-year-old woman previously received 60 Gi for stage 1 cancer. After 2 years, she develops isolated mediastinal recurrence and is considered for reirradiation. Which of the following is the most critical determinant of whether reirradiation is feasible? A. Time interval since prior radiation treatment. B. Total biologically effective dose bed from initial treatment. C. Proximity of recurrent tumor to critical structures. D. Presence of systemic metastasis. Answer. C. Proximity of recurrent tumor to critical structures. Explanation. While time since prior RT and total bed influence reirradiation tolerance, the most critical factor is the proximity of recurrent disease to dose-limiting structures, e.g. spinal cord, esophagus, heart. Dose constraints must be carefully calculated to prevent severe toxicities such as tracheoesophageal fistula or myelopathy. Modern techniques, proton therapy or adaptive RT, can improve reirradiation safety. Question 13. Palliative radiation therapy. Bone metastasis. A 68-year-old man with metastatic prostate cancer presents with painful vertebral metastasis but no spinal cord compression. The oncologist recommends palliative radiation therapy. What is the preferred fractionation schedule for pain relief based on clinical evidence? A. 30 Gi in 10 fractions. B. 20 Gi in 5 fractions. C. 8 Gi in 1 fraction. D. 40 Gi in 20 fractions. Answer. C. 8 Gi in 1 fraction. Explanation. Randomized trial C. RTOC 9714 show that a single 8 Gi fraction provides equivalent pain relief to longer fractionation schedules while being more convenient for patients with limited life expectancy. While 30 Gi in 10 fractions is commonly used for more durable control, single fraction RT is the preferred choice for uncomplicated bone metastasis unless spinal instability or cord compression is present. Question 14. Brachytherapy in cervical cancer. A 48-year-old woman with FIGO stage IB cervical cancer is undergoing definitive chemoradiotherapy with external beam radiation therapy followed by intracavitary brachytherapy. Which of the following is the most important dosimetric goal when planning brachytherapy? A. Keeping bladder dose 60 Gi. B. Delivering at least 80 Gi to the high-risk clinical target volume AEV. C. Minimizing dose to the sigmoid colon. D. Ensuring coverage of pelvic lymph nodes. Answer. B. Delivering at least 80 Gi to the high-risk clinical target volume AOEV. Explanation. For locally advanced cervical cancer, EOEV tumor volume at the time of brachytherapy must receive 80-90 Gi for effective tumor control. Organs at risk. Constraints e.g. bladder, rectum, sigmoid are important but secondary to tumor dose escalation. Guidelines from ABS, American Brachytherapy Society, and Embrace studies recommend achieving these doses while respecting all constraints. Question 15. Radiation-induced toxicities. A patient undergoing radiation for rectal cancer experiences severe diarrhea and tenesmus 4 weeks into treatment. Which radiation-induced toxicity is most likely responsible? A. Acute radiation enteritis. B. Chronic radiation proctopathy. C. Radiation myelopathy. D. Hemorrhagic cystitis. Answer A. Acute radiation enteritis. Explanation. Acute radiation enteritis occurs within weeks of treatment due to damage to rapidly dividing intestinal mucosa. Symptoms include diarrhea, cramping, and urgency. Chronic proctopathy occurs months to years later and manifests as rectal bleeding or strictures. Question 16. Proton therapy advantages. A pediatric patient with medulloblastoma is being considered for proton therapy instead of conventional photon therapy. What is the primary advantage of proton therapy in this setting? A. Reduced risk of secondary malignancies. B. Better tumor coverage. C. Lower risk of acute radiation side effects. D. Higher radiation dose to the target. Answer A. Reduced risk of secondary malignancies. Explanation. Proton therapy spares normal tissues due to the Bragg peak effect, reducing late toxicities and secondary malignancy risks. This is particularly beneficial in pediatric patients who have a higher risk of developing secondary cancers from radiation exposure. Question 17. Total body irradiation. EBI, a patient undergoing allogeneic stem cell transplantation for leukemia, is planned to receive total body irradiation (TBI). What is the primary goal of TBI in this setting? A. Eradicate malignant cells while sparing normal bone marrow. B. Homogenize radiation dose across all organs. C. Suppress immune rejection and enable engraftment. D. Minimize acute toxicity. Answer. C. Suppress immune rejection and enable engraftment. Explanation. TBI serves two main purposes: myeloablation to eliminate the patient's bone marrow, immunosuppression to prevent graft rejection. Question 18. Oligometastatic disease and stereotactic ablative radiation therapy. Seba, a 62-year-old woman with oligometastatic non-small cell lung cancer (SLIM), has a single liver metastasis and is responding well to systemic therapy. The oncology team is considering stereotactic ablative radiotherapy (SABA) for the metastases. Which of the following most accurately describes the role of SABA in oligometastatic SL? A. SABA is ineffective for oligometastatic disease because systemic therapy alone provides superior outcomes. B. SABA improves local control and may improve progression-free survival. C. SABA is only useful if there is complete systemic response to chemotherapy. D. SABA is contraindicated in patients with performance status 2. Answer. B. SABA improves local control and may improve progression-free survival. Explanation. Recent trials e.g. SABA Comet have shown that SABA improves progression-free survival and possibly overall survival in oligometastatic patients. It provides excellent local control with limited toxicity. While systemic therapy remains the primary treatment, SABA offers additional benefit in well-selected patients. Question 19. Radiation treatment for glioblastoma. Jabim, a 58-year-old male with newly diagnosed glioblastoma (GBM), underwent maximal safe resection. The neuro-oncology team is planning adjuvant therapy. What is the standard adjuvant radiation dose and concurrent chemotherapy regimen for this patient? A. 45 Gy in 25 fractions plus concurrent temozolomide. B. 60 Gy in 30 fractions plus concurrent temozolomide. C. 70 Gy in 35 fractions plus concurrent bevacizumab. D. 54 Gy in 30 fractions plus concurrent cisplatin. Answer. B. 60 Gy in 30 fractions plus concurrent temozolomide. Explanation. The STUT protocol remains the standard of care. 60 Gy in 30 fractions, 2 Gy per fraction concurrent temozolomide 75 mg daily during RT. Adjuvant temozolomide 150-200 mg for 5 days per cycle for 6 cycles. Hypofractionation 40 Gy in 15 fractions maybe for elderly patients. Question 20. Breast cancer radiation. Hypofractionation. The 55-year-old woman undergoes lumpectomy for early-stage breast cancer. She is considering hypofractionated whole breast radiation instead of conventional fractionation. Which of the following is a benefit of hypofractionability compared to conventional fractionation? A. Increased risk of late fibrosis. B. Equivalent local control with reduced treatment duration. C. High rates of cardiac toxicity. D. Inferior cosmetic outcomes. Answer: B. Equivalent local control with reduced treatment duration. Explanation: hypofractionation E. G4042.5 Gi in 1516 fractions has been proven equivalent in local control and cosmetic outcomes to conventional fractionation 50 Gi in 25 fractions. Large trials e.g. START A, START B, and Canadian trials confirmed hypofractionation is safe and effective, reduced treatment burden. Question 21. Adaptive radiation therapy. A 67-year-old male with locally advanced bladder cancer (TNM) is undergoing definitive chemoradiation. Due to tumor shrinkage and bladder filling variations, the oncology team is considering adaptive radiation therapy. What is the primary advantage of ART in bladder cancer treatment? A. Reduction in systemic toxicity. B. Improved radiation delivery precision due to daily imaging-based adjustments. C. Elimination of the need for chemotherapy. D. Increased radiation dose beyond standard protocols. Answer: B. Improved radiation delivery precision due to daily imaging-based adjustments. Explanation: adaptive radiation therapy (ART) allows for daily or weekly plan modifications based on anatomical changes, reducing toxicity while maintaining target coverage. In bladder cancer, ART accounts for bladder volume changes, reducing unnecessary dose to surrounding tissues. Question 22. Esophageal cancer. Radiation dose escalation. A 65-year-old man with STID-ROM esophageal squamous cell carcinoma is undergoing chemoradiation. The standard radiation dose for definitive treatment is 50.4 Gi in 28 fractions. What was the primary finding of RTOG 8501 and RTOG 9405 trials regarding dose escalation in esophageal cancer? A. Higher doses, 64 Gi, improve survival with reduced toxicity. B. Dose escalation beyond 50.4 Gi does not improve survival but increases toxicity. C. 70 Gi is the optimal dose for esophageal cancer treatment. D. Radiation dose should be reduced to 40 Gi in patients receiving chemotherapy. Answer: B. Dose escalation beyond 50.4 Gi does not improve survival but increases toxicity. Explanation: RTOG 9405 in 123 demonstrated no survival benefit for dose escalation beyond 50.4 Gi, but higher doses led to increased treatment-related deaths. 50.4 Gi remains the standard for definitive OTA. Question 23. Radiation pneumonitis. Risk factors: a 73-year-old male with STID-ROM cancer undergoes radiation therapy. 2 months later, he develops dyspnea, dry cough, and ground glass opacities on CT scan. Which of the following is the most significant risk factor for radiation pneumonitis? A. Tumor histology. B. Mean lung dose MLD 20 Gi. C. Patient age. D. Use of concurrent chemotherapy. Answer: B. Mean lung dose MLD 20 Gi. Explanation: radiation pneumonitis risk strongly correlates with mean lung dose MD/LD 20 Gi, and V30% significantly increase the risk of symptomatic pneumonitis. Other risk factors include concurrent chemotherapy and pre-existing lung disease. Question 24. Prostate cancer. ORT versus conventional RT. A 70-year-old man with low-risk prostate cancer SSF5.2 Gleason 6 TC is considering stereotactic body radiation therapy SRT instead of conventional radiation. Which of the following is a primary advantage of SRT for low-risk prostate cancer? A. Short treatment duration with equivalent biochemical control. B. Reduced genitourinary toxicity compared to conventional RT. C. Decreased rectal dose compared to emitted. D. Improved erectile function outcomes. Answer: A. Short treatment duration with equivalent biochemical control. Explanation: SRT delivers high dose per fraction e.g. 36.25 Gi in 5 fractions, achieving equivalent cancer control while reducing treatment duration. However, SRT may have slightly increased acute urinary toxicity compared to EMS. Question 25. Gastrointestinal cancers. Dose constraints: a 68-year-old man with pancreatic adenocarcinoma is receiving chemoradiation 50.4 Gi in 28 fractions before surgery. Which of the following is the most critical dose constraint to minimize toxicity? A. Mean liver dose 30 Gi. B. Duodenum D max 50 GI. C. Kidney mean dose 18 GI. D. Bowel loop V 50%. Answer B. Duodenum D max 50 GI. Explanation: duodenal toxicity, G. Ulceration, perforation is the most critical concern in pancreatic RT. Emax should be 50 GI to avoid grade 3 complications. Question 26. Spinal cord tolerance. Radiation oncology. A patient with metastatic spinal disease tail is receiving palliative radiation therapy. What is the maximum spinal cord dose constraint to prevent myelopathy? A. 30 GI in 3 GI fractions. B. 45 GI in 25 fractions. C. 50 GI in 2 GI fractions. D. 60 GI in 30 fractions. Answer B. 45 GI in 25 fractions. Explanation: the spinal cord tolerance limit is typically 45 GI in conventional fractionation. Exceeding this dose increases myelopathy risk. Question 27. Head and neck cancer. IMIT versus a 62-year-old male with oropharyngeal squamous cell carcinoma TIA positive is scheduled for definitive concurrent chemoradiation therapy. The radiation oncology team is deciding between intensity-modulated radiation therapy (IMIT) and 3-conformal radiation therapy (3DRT). Which of the following is the primary advantage of it over 3DRT in head and neck cancer treatment? A. IMIT improves overall survival compared to 3DRT. B. IMIT provides better local tumor control rates than 3DRT. C. IMIT reduces long-term toxicity, particularly xerostomia and dysphagia. D. IMIT eliminates the need for chemotherapy in HPV-positive patients. Answer: C. IMIT reduces long-term toxicity, particularly xerostomia and dysphagia. Explanation: IMIT has not been shown to improve overall survival or tumor control compared to 3DRT, but it significantly reduces toxicity. IMIT reduces radiation dose to the salivary glands, pharyngeal constrictor muscles, and spinal cord, leading to less xerostomia, dry mouth, improving quality of life, reduced dysphagia and aspiration risk, especially in HPV-positive cases, better preservation of taste and speech function. IMIT is now the standard of care for head and neck cancers due to its ability to deliver highly conformal dose distributions while sparing normal tissues. Question 28. Cervical cancer. Brachytherapy dose optimization. A 48-year-old woman with locally advanced cervical cancer, FIGO stage A, bulky tumor, is receiving definitive chemoradiation followed by brachytherapy. Which of the following best describes the importance of image-guided brachytherapy (IGT) in cervical cancer treatment? A. IGT is primarily used to reduce radiation dose to the tumor. B. IGT improves local control and reduces toxicity compared to traditional point-based planning. C. IGT is unnecessary if external beam radiation (EBRT) is well planned. D. IGT is used only for palliative patients and does not impact survival. Answer: B. IGT improves local control and reduces toxicity compared to traditional point-based planning. Explanation: image-guided brachytherapy (IGT) has revolutionized cervical cancer treatment, replacing traditional pointer-based planning with volume-based dose optimization. Studies like EMBRACE and RETROEMBRACE have demonstrated higher local control rates, 85–90% for advanced cervical cancer, reduced rectal and toxicity by optimizing dose to the high-risk clinical target volume AOEV, better overall survival and fewer late complications. IGT allows real-time adjustments based on tumor regression, improving treatment precision. It is now the standard approach for brachytherapy in locally advanced cervical cancer. Question 29. Radiation necrosis versus tumor recurrence. Imaging features: a 55-year-old male with glioblastoma GBM underwent maximal resection, followed by standard chemoradiation 60 GI with concurrent temozolomide. 6 months later, a new enhancing lesion appears at the tumor site in MRI. Which of the following MRI features is most suggestive of radiation necrosis rather than tumor recurrence? A. Progressive enhancement with increased perfusion on dynamic contrast enhanced MRI. B. Increased choline to creatine ratio on MR spectroscopy. C. Decreased relative cerebral blood volume (REV) on perfusion-weighted imaging. D. Rapid growth of the lesion within 1 month. Answer: C. Decreased relative cerebral blood volume (REV) on perfusion-weighted imaging. Explanation: differentiating radiation necrosis from tumor recurrence is critical in post-radiation brain tumors. Imaging characteristics: Radiation necrosis decreases EUV on perfusion MRI due to lack of neovascularization. Low metabolic activity on PET scans. Necrotic core with irregular enhancement and MRI. Tumor recurrence increase EUV due to tumor angiogenesis. Elevated choline to creatine ratio on MR spectroscopy. Progressive lesion growth over weeks to months. Perfusion-weighted imaging is one of the most reliable ways to differentiate between radiation necrosis and tumor recurrence. Question 30. Stereotactic radiosurgery. Brain metastasis. A 68-year-old male with STID Romanin small cell lung cancer SLCR has 3 asymptomatic brain metastases, LADA equals 2.5 centimeters. The oncology team is debating between stereotactic radiosurgery (SRS) and whole brain radiation neurable. Which of the following statements about SRS recovery for brain metastasis is correct? A. SRS provides better overall survival but in patients with multiple metastases. But B. Significantly reduces the risk of local recurrence compared to SRS alone. C. SRS leads to better cognitive function preservation compared to B. It'd be used as first-line therapy for patients with 4 metastases. Answer. C. SRS leads to better cognitive function preservation compared to B. Explanation. SRS is now preferred to B for limited brain metastases 1. 4 lesions due to better cognitive outcomes with similar survival. Key evidence. The JCOG 0504 trial and NRBN trial showed that SRS significantly preserves cognitive function compared to BUE associated with cognitive, particularly in memory and executive function. Local control is excellent, 85.90% with SRS. That there is a slightly higher risk of distant brain metastasis, but is still used in patients with multiple 4-5 metastases, leptomeningeal disease, or poor performance status. However, for patients with 1-4 metastases, SRS is preferred due to neurocognitive benefits.